talking about it a lot and garners significant attention from the field. One of our textbooks by Lisa Levers. Let's talk about dissociation defined. Dissociation disorders are well covered in the DSM, and you're going to hear me talking about it a lot, and garners significant attention from the field. One of our textbooks by Lisa Levers, Trauma Counseling, written in 2022, will also be used a lot in this presentation. There is a significant connection with dissociation disorders, or DDs, when trauma is present. I don't think that is surprising to anybody. Levers describes these disorders as the individual separating thoughts and feelings from the physical body. This is a part of a normal trauma response. We see that in a study from Clausen and others, and should be treated by a trauma-informed therapist. And Levers is very specific on that when she talks about that. In many cases, patients who frequently dissociate have symptoms that can be a predictor of post-traumatic stress disorder, though I think most in the field would argue that if you have a DD, you have PTSD because of the role of trauma in DDs. A traumatic and painful memory is often the culprit when a person is dissociating. Patients separate their emotions from their bodies, right? We're built to not want pain, often feeling disconnected from the world and themselves. The DSM 5 describes dissociation as interrupting the whole body integration. This can and does cause significant psychological interruption with a high probability of co-occurring disorders, which we will be talking about. Why do we dissociate? Everyone dissociates. I was in session with my counselor the other day, and I said, do I dissociate? And he said, everybody dissociates. It's the 1,000-yard stare. It's the things that we're doing when we are driving, the things that we can do automatic. But when dissociation becomes a problem is when we are disassociating to avoid traumatic and painful memories. We deeply want to achieve emotional regulation, and we want to relieve some somatic issues. And so everyone disassociates, but certainly associated with trauma. This was fascinating to me. The neurobiology of dissociation brain scans demonstrated changes in both functional altercations and structural. And one of the ones that is most altered is the hippocampus, which we know is the fear center. And I think in one of these classes, the fear center, it was referred to as the amygdala being the CPU, and the hippocampus being the keyboard that kind of expresses what's going on in the fear center. And so in these patients that with DDs, we saw altercations and reductions in hippocampal volume, as well as other alterations to brain structure. What are some of the symptoms? Sanderson outlines these well: memory loss, time loss and time distortion. Really interesting. Patients literally lose track of time and what they did during that time. Depersonalization, where they feel separate from themselves and even separated body parts from themselves. I had an interview for one of these classes with a young lady who explained her traumatic experience to me, and a couple of days later she sent me a text familiar with her own propensity to dissociate, and said to me, I looked at my hand and it felt like it was somebody else's. And we'll talk about that a little bit more. But patients who report feeling numb or disconnected from their bodies with little control over function, and then these patients alternate, as you would expect, between hypo and hyperarousal. Risk factors. This fascinated me. People with high adverse childhood experience scores and low mentalization scores are more likely to suffer from the ills of dissociation. Wagner and al. Studied the impact of mentalization and dissociation, and lower mentalization correlated with higher dissociation rates. Additionally, those exposed to domestic violence are highly likely to have DDs. And their study, Summer and al. Found that 91%, y'all, of battered patients met the criteria for DDs. Because of the nature and the criteria for PTSD, there's likely going to be a dual diagnosis for PTSD, just because PTSD is a trauma disorder, and so is DDs. And so when treating PTSD patients when PTSD patients are showing signs of dissociation, it is advisable to first treat the PTSD, stabilize the patient before trying to address the DDs. And Sanderson outlines outlined, that for us. While not as common as some would make it, there is a subset of patients who are also diagnosed with other things like borderline personality disorder. I'll talk about that in just a minute. How do we assess it? There are a few assessments: clinical interviews. The structured clinical interview for dissociative disorders, or SCID, has demonstrated validity in diagnosing dissociative disorders and also differentiating between the known DDs. The DSM criteria is an excellent tool for dissociative disorders. When using both the DSM-4 and the DSM-5, clinicians accurately diagnose 95.27% of patients with DDs, and only a little under 84 of those, though, met every DSM criteria. We all know that the DSM needs some work still. But standard psychological assessments can also be used, such as the dissociative experience scale, very valid. It continued to be proven in diagnosing these the DDs, as well as adequately differentiating and diagnosing schizophrenia, which is significant because DID, especially of all the DDs, can be confused for schizophrenia. And when I say DID, I'm talking about dissociation identity disorder. The dissociative experience scale was proven valid and should continue to be used. And then Owen Al in 2015 proved that again when assessing for dissociative disorders. When we diagnose it, we need to consider differential diagnosis. All these are provided by the DSM: dissociative amnesia and depersonalization and derealization, and then major depressive disorder, bipolar disorder, PTSD, schizophrenia, and other psychotic disorders. I find it interesting that the DSM does not mention differential diagnosis of borderline personality disorder. And so that fascinated me, so I went for more research. So I work in an emergency room in the behavioral health, and we see a lot of patients who come in, and I see a lot of diagnoses of borderline personality disorder. Diagnosing DDs can be challenging because of their likeness to other mental health disorders like BPD, borderline personality disorder. Both of them share symptoms, and they both share risk factors such as alteration in mood, self-harm, identity issues, and dissociative identity disorder in particular shares depersonalization and derealization. No significant difference is found in measuring these symptoms in both disorders. However, there are unique symptoms to BPD, and this is what I think my docs at my hospital are not paying attention to. Patients with BPD can remember actions and emotions and do not feel a loss of time. Very, very big marcation between DID and BPD. Patients diagnosed with DID experience amnesia and lose sense of agency. DID patients assessed by the SCID demonstrated identity issues at a greater rate than those diagnosed with bipolar disorder, borderline personality disorder. Also, using the ink blot test, the BPD patients demonstrated greater self-reflective capacity and could manage emotions better than those diagnosed with DID. Still, significant data indicates that 24% of patients with DID are also diagnosed with borderline personality disorder. The inverse is true, with only 11% of BPD patients diagnosed with DID. And I don't know if the docs at the hospital go for the higher acuity disorder, and that's why they label them all BPD, and I don't see any DID diagnosis, but we are in the ED, and so that just fascinated me based on some experience that I have. Different types of DDs: dissociative amnesia, depersonalization, derealization, structural dissociation, and DID, which is what we're talking about. Dissociative amnesia, based on the DSM criteria, is the inability to recall autobiographical information, usually traumatic and stressful in nature. I find that to be personally true about my own trauma narrative. The symptoms can cause clinical significant distress or impairment in social, occupational, or other important functions. More DSM criteria on dissociative amnesia. The disturbance is not attributable to psychological effects of a substance. I'm going to make sure they're not altered for that reason. We also want to rule out a bunch of other things like PTSD, which is probably co-occurring, but acute stress disorder, somatic symptom disorder, or major or mild neurocognitive disorders. We want to make sure those don't better explain the behavior before we label them with dissociative amnesia. Prevalence in the United States in a small community, small sample, wouldn't put too much stock in this, but about 1.8%. What are the consequences if we don't pay attention to dissociative amnesia? Difficulty in forming attachments, compulsively overwork. I'm beginning to wonder if I have this because that is true of me. Chronic influence in most areas of life. Depersonalization, derealization. I talked a few minutes ago about the young lady that I interviewed that reported not being able to see her hand as part of her body. That is a real thing. And we, in my opinion, are climbing up the scale on DDs when we're not treating dissociative amnesia. We get to this part. I don't know if it's linear. I didn't find anything telling me that it's linear, but logic tells me that it's linear, that if we don't take care of it at the beginning, and we know we want to get to trauma fast and deal with it so that we don't have these altercations and these disorders like we're seeing. Derealization, experiences of unreality or detachment with respect to surroundings. Interesting. DSM criteria, the presence or persistence of reoccurrent experiences. So if Rachel continues to see that, it continues to feel that, continues to be like, is that my hand? Then that would be persistent and reoccurring. During the depersonalization or derealization process, they still could be in real time. And so that is a criteria for this too. The symptoms cause clinical distress and impairment in social, occupational, and other areas of functioning. I don't think that's excuse me, I'm sorry, I lost my slides there, it scared me. Need to not be attributed to another mental disorder. Sorry about that, that freaked me out. What are the functional consequences of not paying attention to this? You notice we're stepping up the ladder here. Incongruence with extreme emotional pain, interpersonal impairment, occupational impairment, disconnected from life. And again, the DSM is the place I went for these because it outlined it the clearest. And in my opinion, the DSM doesn't have an end game as some studies might. And so I use the DSM for a lot of these slides coming up for that reason. This one I found incredibly, this is another type of dissociation, structural dissociation, which Howell in 2005 described as a separation of mental and experiential contents that would normally be connected. Explains a coexistence, though, between the high-functioning self and the injured self. Again, I wonder if that is my story, and it explains the detachment process. This is structural dissociation. We have 3 different types of structural dissociation. We have primary structural dissociation. This is where the ANP, the apparently normal personality, seeks to separate itself from all traumatic memories and experiences. The emotional personality stays entrenched in the trauma and painful memories, as outlined by Sanderson in his book. Some people can live high-functioning lives by operating inside the ANP. However, that EP remembers that all the effects of the unresolved trauma are still at play, even though the person is high-functioning. And then we move to secondary structural dissociation. Now, the emotional personality is breaking off into parts, and we're beginning to see those different personality states. And then we still have a single normal personality, apparently normal personality, and secondary. But look at what happens when we get to tertiary. The AP now is the apparent normal personality is now completely overwhelmed. It begins to fragment, and this leads to dissociative identity disorder. This is interesting. DID seems to be the most severe of the 3 dissociative disorders and is listed first in the DSM. Since the most important benchmark of DID is 2 distinct personalities, it's very difficult to diagnose. It delays treatments, and ultimately the patient suffers more than necessary. So we might want to be a little bit careful as helpers in this. We don't want to label people that, but if we, as we saw when we use that DSM, only 84% of those patients met every criteria for DID. So we need to be careful about this, but I think that this is good information from the DSM, characterized by 2 or more personality states, by recurring episodes of dissociative amnesia, intrusive thoughts, which is also, of course, associated with PTSD, characterized by an altered sense of self, and characterized by feelings of attachment from the body. And so that is DID in a nutshell. The DSM criteria for this is disruption of identity. We just talked about all of those things. Reoccurrent gaps in the recall of everyday events, important personal information, and traumatic events are inconsistent with ordinary forgetting. Find that really interesting, that last part, the ordinary forgetting. Again, the DSM criteria, the symptoms cause clinically significant distress, or impairment in social, occupational, other areas of function, and it's not part of a normal, broadly accepted cultural religious practice, which we'll talk about here in a minute. The symptoms are not attributed to psychological effects of a substance or another medical condition like we've seen in the others. Incidence rates. Now, it depends where you looked on this. I chose the studies that I found first, but then later I found some studies that said this probably is vastly underdiagnosed. But so I chose to stick with the study that I spent some time on. And Burzik in 2023 said this is pretty recent, obviously, continues to maintain that it is rarely diagnosed, and perhaps that is because of the difficulty in diagnosing. I don't know. It is thought to occur in 1% of the population. Now, the thing that seemed to be consistent in the research is how long it took to arrive at a DID diagnosis. This study in particular said 6 to 8 years. It had a misdiagnosis of 2.8. That means 3 different things before, 3 different diagnoses before they got to a diagnosis of DID. Let's talk about the demographics. Overwhelmingly female, which absolutely blew my mind, and it's really, really interesting. It made me want to take a deep dive into why. Really, seriously, if I hadn't already picked my dissertation topic, that might be this might be part of it. But the median age 26.5, I found also interesting, as we know in the field that at age 25 the brain is probably done. And so the median age at 26.5, we could accurately probably diagnose and not be confused with some of the lack of brain development. It's not surprising that almost 70% has coexisting disorders. I was shocked, though, that 64.28% of patients with DID reported physical abuse. And sexual abuse was high, too, but chronic neglect almost 50%. And I picked those because that's my story. But I don't have DID. Thank you, Jesus. The dangers of it, about 80% of DID patients will experience auditory hallucinations. See that a lot in the ER too. Don't think we're talking to them. The challenge with auditory hallucinations is to differentiate between schizophrenia and DID. Patients misdiagnosed with either of these is problematic and could present danger for patients. In terms of auditory hallucinations, the danger, of course, for patients is an increased risk for suicide. Those same patients have dangers of self-harm and dangerous behavior if not in treatment. Only 28 to 48% with any dissociation disorders are in treatment, which is sad to me, and why we do what we do. Some barriers to treatment probably account for that. The low amount of patients seeking mental health care. Unfortunately, there's just a mistrust among patients, and because they're, as we saw, often misdiagnosed, repeatedly hospitalized, and repeatedly dismissed. I see that a lot in the ER because we do get patients who don't take their meds and they just come back. And I'm not even kidding, like 2 and 3 times a month. And so unfortunately, healthcare workers grow weary of that and patients grow mistrustful of them. And it is a perfect storm. But we see the DID dangers in addition to suicide attempts, barriers to treatment, self-harm, and dangerous behaviors. And that would include drinking, driving, drugs, that kind of stuff. Functional consequences of not paying attention. This too fascinated me. You could both the DSM reported you could have both poor academic performance and above academic performance. That kind of shocked me. So I took a little bit of a deeper dive in that. And the reason for that was the patient who with the above average academic performance used their dissociation essentially as a superpower. And that's where they went, and they spent all their mental capacity on academics. Poor academic performance made sense to me. Now, we know that there are familial issues. One of these classes is adult and familial trauma. And I see it all the time in the ER with patients with DDs that their family are just done because they don't understand, because of all of the issues that come from having 2 or more distinct personality states. Looks weird to people looking on the outside. Comorbid positions, comorbidity conditions is the word I was trying to say. These shouldn't surprise anybody. Seizures, gait disturbances, and paralysis. Now, let's talk about culture in DID, because this was really important and really fascinating to me in the DSM. Some cultures believe that they're separate parts in their bodies. And they believe there's spirits and deities and demons and animals. And so we need to be careful when we are diagnosing DID, because the idea of having different parts of you is in fact part of cultures. Also, we need to be careful because mental health help isn't always accepted in cultures, even ours. Let's talk about treatment. My favorite subject, EMDR therapy, prolonged exposure, physical therapy, psychoeducation, and group therapy. Some patients who participated in an intensive, it was a 2-week program, trauma-informed program that met the criteria for DID and PTSD. After 2 weeks of treatment of EMDR therapy, physical therapy, psychoeducation, and group therapy, these patients no longer presented with that no longer met the DSM criteria for DID. And so the researchers hypothesized that with the reduction of the PTSD symptoms with modalities like EMDR, prolonged exposure, that patients didn't need to dissociate because they had properly dealt with and processed the traumatic memory. Let's talk about EMDR. EMDR is fascinating. We know that Francine Shapiro came up with it in the late 90s, and the story goes that she went to Central Park, and this is a story told to me by my therapist. I couldn't find it anywhere to document it, but and I think it might even be in her book, but that it didn't have access to. But she was in Central Park after a traumatic memory, something happened, and she noticed as she moved her eyes to look at the birds flying that the traumatic memory seemed less vivid, and she took that and ran with it. So the underpinnings of EMDR are based on the adaptive information processing model, which of course holds that we do not lay down maladaptive memories properly and that they cause problems. And so she based EMDR with bilateral stimulation on the underpinnings of we need to make sure that we take care of these maladaptive memories because they're causing problems like DDs. And so there's we really don't understand why EMDR works, if everybody's being honest, but there are 2 hypotheses that I found that I think makes a lot of sense. One is the working memory hypothesis, and that holds that because we are stimulating bilaterally the brain, that while processing a traumatic memory, that the brain gets a little bit overwhelmed, and suddenly the traumatic memory is not as vivid because the brain is trying to figure out what's going on in real time. And the bilateral stimulation, maybe even more fascinating than that, the bilateral stimulation seems to mimic slow sleep waves, and of course, which we know helps us with memory consolidation. Prolonged exposure aims to help the client avoid helps the client stop avoiding the traumatic memories, so they can integrate the whole self without dissociation, which of course we know leads to DID. When prolonged exposure is used in treatment, the client is asked to bring the traumatic memory to the top of their memory and just be immersed in it. And one example was writing a victim impact statement. And so prolonged exposure was part of that 2-week group where those patients walked out without not having met anymore the criteria for the DSM criteria for DID. The benefits of treatment: improved quality of life, obviously the reduction of health risks, reduction of social risks, and reduction of healthcare costs. Boyer in his study, Boyer and others found that there was a 25 to 64% reduction in healthcare costs when properly diagnosed. The ills, of course, increased suicidal ideation, self-injurious behaviors, increased likelihood of re-victimization. 70% of patients with DID have attempted suicide at least once. And I want to pause there because 70% of patients have attempted suicide at least once and are repeatedly hospitalized. These patients are likely to have a plan. These are the ones when they come into the ER, they have a plan. There is no doubt that the desire to get out of the emotional turmoil and pain is what sends them there. Self-injurious behavior is prominent too in this population, but about 93% of those patients report unawareness of their self-injurious behavior. DID patients, if not treated, are subject to re-victimization, which is perhaps the saddest of all. Disability. In a sample, 60% of patients described themselves as disabled. They reported difficulties across multiple domains. Patients are hampered by DID and therefore have a poor quality of life and physical health. There are many physical issues related, including cardiovascular disease, diabetes, and inflammation. About half of the adults with DID report hospitalizations, most with fewer than 5. about 35% of those patients were admitted via emergency rooms. Did accounts for about $2,300 per patient compared to $300 in other groups of mental disorders. And so dissociation, all of the disorders are problematic and something that those of us here in the trauma field need to move forward. But wait, but God. So what if we looked at dissociation as a gift from God? What if we looked at it as a fulfillment of promise of 1 Corinthians 10:13, where the Bible says there is no temptation taken you such as common in man, but God is faithful and will provide a way of escape? What if benign dissociation is a gift from God? What if? And then we as Christian helpers in the field know when that line is and when it's not a gift anymore and when it's a problem. But what if it is the way of escape promised to us in 1 Corinthians 10:13? We know that way of escape was Jesus. What if he is our way of escape? We also know just by Jesus' behavior in the garden that he did not disassociate. And my question to you is, does that make the gift of salvation sweeter? He is fully immersed in all the trauma and all the pain. Hebrews 4:15, which I do not have listed here, and I'll just take the points off. But Hebrews 4:15 tells us we do not serve a high priest who is unfamiliar with our sufferings. Jesus did not dissociate. Does it make the gift of salvation sweeter? Hope in the church. It's us, y'all. The church needs to be educated about dissociative disorders. We need to stop thinking those people are weird. When one part of the body is not functioning correctly, the whole body is affected. We see that in 1 Corinthians 12:26. That's talking about the church. But guess what else it's talking about? It's talking about trauma. It's talking about dissociation. Can we apply the truth of Scripture to help patients with dissociation disorders? Absolutely. The Bible is the answer to everything. Should the church leadership be trained to help people early and often so the progression of dissociation is halted? I think the answer to that question is absolutely. So as we are studying different trauma-related disorders, dissociation disorders are prominent and important, and people lose their lives when they're not treated. And so let's go treat them and show them the love of Jesus.